Great, well, welcome everybody to the session today. Just seeing the participants roll in, so we'll give them a second. But as an introduction, my name is Scott Weiner. I'm an emergency physician at Brigham and Women's Hospital in Boston. I'm also fortunate to be the director of the B Corp program, which is the Brigham Comprehensive Opioid Response and Education Program. I also lead with Gloria Brand the POPI Initiative, which is the Program in Opioid and Pain Innovation. We are delighted to be in partnership with the HMS Center for Global Health Delivery for this seminar entitled Opioid Use Around the Globe. As I mentioned, I do work in the emergency department. For the past 20 years, I have seen the toll of the issue of opioid use disorder. I've taken care of patients who have had come in with withdrawal, medical complications of opioid use, and of course, people who have had opioid overdose and overdose death. It's something that is unfortunately an issue that we deal with on a regular basis. We've been struggling with this opiate epidemic for the past 2 decades now, and it's now getting worse because of COVID, unfortunately. We're seeing greater disparities and increased numbers of lives lost, and it's just tragic. But I'm hopeful because there are pockets of hope and ideas that are happening around the world. And that's really the premise for this conference, is this series, is that we want to learn from each other, because in different countries which are struggling with this disease, there have been different solutions which have been proposed, sometimes outside the box, sometimes it's policy, sometimes it's regulatory, and there have been some glimmers of hope. And I'm truly a globalist, and I know that this disease knows no borders, and so I'm hopeful that we can learn from each other by highlighting different innovative approaches which are happening around the world. Again, I just want to thank the collaboration we have with the Center for Global Health Delivery and with POPI, and thank you all for attending. So to kick it off for this first series, we will be featuring North America, and we're delighted to have a speaker from the United States and a speaker from Canada. And I'll introduce them now. Our first speaker, who's from the US, is Deepa Avula. She is the former director of the Office of Financial Resources at the Substance Abuse and Mental Health Services Administration, or SAMHSA. For those of you who are from outside the US, SAMHSA is the major agency which occupies itself with treatment for a lot of mental health and substance use disorder initiatives in our state. Ms. Avula comes to us with over 20 years of experience in issues related to behavioral health policy, programming, budget, and data at the federal level. And at SAMHSA, she had direct responsibility for overseeing the successful execution of the agency's $10 billion budget. She also was instrumental in the agency's response to COVID-19. And we are really delighted to have her here and share her experience working with this incredibly important agency. And our second speaker is joining us from British Columbia in Canada. It's Dr. Mark Tyndall. He is a professor at the University of British Columbia School of Population and Public Health. He is an infectious disease specialist and epidemiologist with a focus on urban health, drug use, and harm reduction. He was formerly the executive director of the British Columbia Center for Disease Control and the deputy provincial health officer. He is a strong advocate and leader for public health, and his main goals have been to establish a safer drug supply and work to change drug policy for the better. And I'm sure you'll be delighted to hear from both of these speakers. We'll start with Ms. Avula. If you want to share the slides, I think Sue is going to do that and take it away, and then we'll ask Dr. Tyndall to speak, and then we will hopefully have a vigorous discussion. So again, welcome to everybody.
Thank you so much. As was noted, my name is Deepa Avula, and my most recent position at the Substance Abuse and Mental Health Services Administration was both as the Chief of Staff and the Chief Financial Officer for the agency. And as Dr. Weiner noted, SAMHSA is the major component in the Department of Health and Human Services, who is primarily charged with reducing the impact of substance use and mental illness on America's communities. So what I would like to do first in this presentation is sort of talk about some of the data that we see related to the opioid crisis in the United States. The best source of information for data on this topic in the US is what we call the National Survey of Drug Use and Health. And essentially, NSDUH is a household survey which does just what it sounds. It surveys households, members of households, randomly to generate estimates of the prevalence and incidence of both substance use and mental illness across the country. One of the things that I will note is because it's a household survey, it leaves out populations such as those individuals experiencing homelessness or individuals who are incarcerated or in other institutional settings. So we do know that the data that NISDA does provide in some ways is actually, even though it's pretty compelling, the data, it's in many ways an underestimate of the actual problem. NISDA is the premier source of behavioral health statistics across the country. One of the things I will also mention is that NISDA is produced annually. So there is a slight lag in the reporting and as compared to when the data were collected. So we'll begin by looking at the overall picture of substance use and mental illness in the United States. In 2019, there were 61.2 million Americans that lived with either a mental illness or a substance use disorder. 19.3 million had a substance use disorder. Of those 19.3 million, about 1.6 had an opioid use disorder. One of the things I noted is that NISDA does have a lag time. So all of these data that I'm going to share are pre-pandemic. So these are pre-COVID data. And obviously, as many of you know, that's a pretty important kind of caveat, because we do expect that some of these numbers will change quite significantly in upcoming years as a result of COVID. When we look at opioid misuse, we see that 10.1 million Americans reported past year opioid misuse. Of those, about 9.7 million reported pain reliever misuse. An additional 745,000 reported heroin misuse, and 404,000 reported both pain reliever and heroin misuse. One of the things that NISDA allows us to do, because we collect both mental health and substance use data, is it allows us to look at different substances and their association with each other, as well as different substance misuse and its association with certain aspects of mental health. And we really are trying to focus in the United States on addressing this major issue of co-occurring disorders. So I'm going to talk a little bit about that. When we look at the data, we see that so the red bar is those who reported no opioid misuse. The blue bar is those that reported opioid misuse. And we can see a strong association between opioid misuse and marijuana use, opioid misuse and heavy alcohol use, opioid misuse and cocaine use, as well as opioid misuse and methamphetamine use. And again, these differences are not small. They're pretty significant in terms of the apparent effect opioid misuse has had on these other substance use prevalence. We also see the same type of trend when we look at opioid misuse and major depressive episodes, and opioid misuse and the reporting of serious mental illness. The next slide looks at substance use disorders in general. So this is not specific to opioid use. The reason that I included this is because it is so compelling to see the difference again here when you compare the blue bar, which is those who have reported no substance use disorder, and the yellow bar, which is those who have reported substance use disorder, and you see the difference in measures of suicidality. So whether it's serious thoughts of suicide, made a plan for suicide, or attempted suicide, you see that those with substance use disorder have significantly higher rates on all of the metrics related to suicidality that the NISDA survey reports. The next slide looks at where individuals report getting the pain relievers that they misused. One of the things that's very important here is that we see that the majority of people are reporting getting the pain reliever they misused from a friend or family member. So that's over 50% are reporting that they got it from a friend or family member. One of the things that's not completely evident on this slide, but it's a really important point to share, is that when we ask people, so you misused it because a friend or family member either gave it to you, sold it to you, you took it from a friend or family member, where did that friend or family member get it? And the overwhelming, so about 83.8% of people reported that their friend or family member got it from a single prescription from a doctor. So the vast majority of people reporting misuse got it from a friend or family member who got it from a single prescription from a physician or a practitioner who could prescribe opioids. So I think that is a pretty important finding, and it's pretty important that the United States has really taken great steps to educate providers around prescription, around careful prescribing practices, but clearly these data say we need to be doing a little bit more. One of the other things that I thought was interesting and important to show is the misuse of prescription opioid subtypes. We see here that the subtype with the highest rate of misuse is buprenorphine. The reason that I feel that it's important to share this is because often we know that buprenorphine is a very effective means of treating opioid use disorder, but we do also know that it can be diverted, and it is not necessarily 100% safe at all times, particularly if diverted. So it's a very important thing for people to be aware of, that buprenorphine is reported to be a pretty significantly misused drug when prescribed. When we talk about the approach to addressing addiction in the United States, we really think about this from kind of an overall whole health approach. So what do I mean by that? What I mean is we are not just solely trying to address the substance use behavior of the individual. We are recognizing that substance use behavior has created a host of other issues in that individual's life. And we are really trying to provide supports and services to address all of the consequences of substance use. For us, kind of conceptually or philosophically, while the measure of opioid use, opioid overdose deaths is obviously critically important. We do not want people to die of any condition, but that is not the sole measure of our success of our programs or of our efforts. What we're also we're not just trying to keep people from dying. We're also trying to keep them living a healthy, productive, happy, socially connected life. And we do that in a number of different ways. So the United States has implemented things like safe syringe exchange. We know that syringe exchange programs are very important for mitigating infectious disease spread, for again ensuring that physical health conditions are less exacerbated. We're also put in place a real focus on medication-assisted treatment. I do want to note that I know that there is talk globally around safe injection sites. In the United States, that is not legal because it is a violation of the Controlled Substances Act. That is something that has just been reaffirmed by the courts. So that is a strategy that is not being pursued right now from either a policy or legal perspective in the United States. What is being pursued and has really had a strength of pursuit is this idea of a continuum of care, a continuum of both community service and individual service. So that this concept of prevention, treatment, and recovery, and focusing in a very kind of laser focused way around those three concepts. One of the things that the Substance Abuse and Mental Health Services Administration did through 2017, from 2017 through 2021, many of these programs obviously still continue today, is we funded a series of programs, again, that have this kind of conceptual framework of prevention, treatment, and recovery. I won't talk in detail about every single one of these programs, but I will talk specifically about a couple. I'll start by talking about the State Opioid Response Grant Program. One of the beauties of that program is that it recognized that every state in the United States is different. So that the strategy that you use in New York is not going to necessarily work in Alaska. The strategy you use in California is not going to necessarily work in Texas. So what these grant dollars did, it allowed each state across the United States to design and develop its own strategy to addressing their local crisis. And it meant that they had to incorporate the conceptual framework of prevention, treatment, and recovery, but they could do that in a way that made sense in their communities. So we had certain evidence-based practices that we looked at in terms of prevention, school-based programs. How are you educating your students? How are you educating your young people? What is the community around people that you're developing from a prevention messaging? One of the things we learned, prevention messaging absolutely happens in the community. It doesn't happen from your state office. It doesn't happen from Washington, D.C. It happens from your faith leaders. It happens from your teachers. It happens from the people that you're interacting with on a day-to-day basis in your community. So one of the real strengths of this program was developing those strong community coalitions. The other thing we learned very quickly at the federal level, we were fortunate to have an addiction psychiatrist that was the first assistant secretary for mental health and substance use, Dr. Eleanor McCants-Katz, who is an expert in the treatment of opioid use disorder. One of the things that she did was, if you received funds from the state opioid response program, it was required that your provider network had to at least make available medication-assisted treatment. We certainly recognize that patients may choose a different option, but the provider network funded by the federal government had to at least have available to every patient medication-assisted treatment. It was a real focus on the kind of acceptance of medication-assisted treatment as a legitimate treatment, as an effective treatment, as an evidence-based treatment. One of the things I'll share is that when we did that, I've been at SAMHSA a long time. I've been in the federal government for 20 years. I have experienced that states don't really necessarily want us to be that heavy-handed. When we did that, states across the country thanked the federal government for stepping in and making that kind of decision, because it made it easier for them to then implement it. It helped them reduce the stigma for both their patients and providers of actually providing such an effective care. The next slide just shares some additional information about some of the other kind of components of the strategy, including things like naloxone distribution. We had a very heavy program related to overdose reversal drugs. One of the things that we also really kind of laser focused on was this idea of workforce development and training. We realized quite early that it is an substance use disorders, opioid use disorder, it is not part of mainstream medical school curriculum. It's not part of healthcare curriculum. And we really kind of pushed universities and schools through grant funding, through providing funding to them, to really start to incorporate and embed this type of training into their programs. The reason that we felt that was so important was because if you don't teach it at a young age, if students don't understand what these conditions are, it is very unlikely that they will feel comfortable treating these conditions as they become practicing practitioners. So that's one of the areas that we really focus on. One of the other things I just want to quickly mention is we had also a state targeted response technical assistance program. I think this is one of our most innovative strategies to addressing the crisis, because what we did here from the federal level is we funded, and we funded it well, we funded training teams in each state across the country. So we provided the funding for it, but the actual service delivery was done by local expertise. And it wasn't provision of services, it was provision of training and technical assistance. So we really got into communities, into kind of, again, sectors of communities as well as treatment programs to help them shape their training and technical assistance response at the local level. A few results from these efforts, and again, these are pre-pandemic data, so this goes from 2016 to 2019, but we can see impressive results here with opioid misuse going down across all age groups from 12 to 17, 18 to 25, 28 or older. We see a significant decline in opioid misuse. Same is true when we look at just prescription pain reliever misuse specifically, we also see those same declines. When we look at heroin use, one of the things that we were really quite pleased to see is that heroin initiation went down, again, speaking to our prevention efforts and really looking at those and the importance of not just treating the problem once it becomes a problem, but really trying to intervene as early as possible to help ensure that it's not a problem for as many Americans as we can. The next slide looks at opioid use disorder. Again, here we see impressive decreases across the board in terms of age group on opioid use disorder. When we look at medication-assisted treatment, again, I spoke to some of the requirements at the federal level. Those did appear to have an impact, with medication-assisted treatment increasing on all three medications. And obviously, overall, we see an increase in those receiving medication-assisted treatment. Now, I just want to take a couple minutes to talk about COVID and its impact. As I said, we were very pleased to see the results that we got, but then came COVID. And one of the things that we know is COVID brought along with it a host of issues related to mental health issues, related to issues that could increase substance use, that could increase opioid use specifically. loneliness, trauma, isolation, unemployment, all of these things we know are risk factors for increased substance use. When we look at some of the mitigation strategies that were put in place, and again, rightfully, we had to address the physical effects of coronavirus. There is no denying that. But one of the things we did not do as well as maybe we could have done was really look across and see, are the efforts that we are, again, laser focused on reducing viral containment, are they producing unintended consequence on these other things? So when we look at, for example, social distancing requirements, when we said 6 feet and countries around the world said 3 feet, did we know that 6 feet was absolutely what was needed? Because what it also did when we said 6 and not 3 feet is it did close mental health treatment centers. It did make it harder for people to get methadone. It did make it harder for people to do in-group group therapy. So as we kind of talk about when we look back at the results of COVID and we see what's happened, we look back at the strategies that we implemented, and we really have to take a very close look at when we put in place this idea that you have to address physical health, which of course you do. There is another critical aspect of health, which is substance use, which is mental health, that should not be considered separate from physical health. It should all be considered whole health because they have really profound impacts on an individual's health. And while we talk about everybody being so excited that there's such a great vaccine that's now available to people, and the vaccine is widely available in the US, which is wonderful. And people say, now COVID can be behind us. For millions of Americans who've either developed a substance use disorder, who have exacerbated their substance use disorder, COVID is not going to be behind them. The results of COVID, the effects of COVID, for millions of Americans will fade because the vaccine has come. For other Americans, that won't be the case. And we just have to be mindful of that. I think that's something we really have to think about. So when we look at going forward, what are we going to do? Going forward, obviously, our efforts will continue to focus on increasing medication-assisted treatment. We'll continue to focus on developing evidence-based practices and paying attention to populations that are disparately affected, for sure. One of the things we also need to do, critically important lesson in the opioid crisis, is you cannot focus on one drug at a time. That is not the way substance use works. So while you are laser focused on treating the opioid use crisis, guess what happened? Stimulants were on the rise. So we have to make sure that we are cognizant that our substance use policy needs to match the way that substance use works in communities, and it's not just one drug at a time. We really also have to continue the focus on workforce development and training, because the more we mainstream these conditions, the more we talk about them the way we talk about any other chronic disease, the better results we'll be able to have, not just for the individuals, but for practitioners who are willing to treat these conditions. Individuals with opioid use disorder deserve the same type of care as individuals with any other type of chronic condition in the United States. And that's something we've really been focused on to try to reduce the stigma to ultimately improve access to quality services. So I will stop there, and thank you so much for your attention.
Great, thank you so much, Ms. Avula, for that excellent talk. I'm sure there's going to be lots of questions about this afterwards, and I'm already excited to see kind of the differences with policy. You probably heard about, the safe consumption facilities are off the table in the US, and we'll move now to Canada where it actually has been used. So I'll hand the floor over to Dr. Tyndall.
Okay, thanks a lot, Scott. So it's a pleasure to be here today. Thanks for asking me. This seminar series clearly has a very ambitious tone to it, with trying to look at opioid use disorders across the globe. And instead of giving a general overview like we just heard, which I think mirrors and reflects a lot of what's going on in Canada, I'd like to just stick to some very specific experiences that we've had in British Columbia, and how the overdose crisis and the rising number of overdose deaths has really unmasked the disaster we have with drug policy. So one of the trajectories I've had with my 25 years or plus working in harm reduction and working with people who are using drugs is that we can come up with all kinds of abstinence-based and programs and recovery programs, but we're still really leaving a large proportion of the most vulnerable people out there without really any lifelines. And until we stop thinking about getting access to people and people getting access to services based on their drug use, we're gonna block it for most people. And I've been advocating that we really have our approach upside down, that most of the programs we're offering people are based on stopping drugs and then we can help you. And from a harm reduction point of view, we really need to as we say, meet people where they're at. And for a lot of people, that is using drugs regularly. And we need to be able to provide services to people while they're using drugs. And if we can take care of some of the other obstacles they have in their lives, they will choose to reduce or stop their drug use. But I think our approach has pretty much been upside down, that the drugs are a problem for you. We have to get you to stop using these drugs, and then we can help you get on with your life. And that doesn't work for a lot of people who view their drug use as a survival tactic, and they're self-medicating to deal with physical, mental, and emotional hurt that they have in their lives. And for a lot of people, the drugs aren't really their problem, and the drugs are really their answer and how they're trying to deal with their problems. And until we start to focus on helping people with that, then we're going to be spinning our wheels. And I'm trying to make the case that we really need to change the way we deal with drugs without making major changes in the war on drugs and the prohibition of drugs, and get away from this idea that we need to be a drug-free society somehow. We're never going to make very much progress. And the prohibition has really led to where we are now with overdose deaths and the rise of fentanyl and synthetic opioids that are just killing far too many people. And when I look at a slide that was presented of reducing number of people using heroin, at least in Canada, that's directly related to supply. It's nothing to do with any kind of programs we've instituted against heroin. It's that heroin is no longer readily available across Canada, and it's been replaced with synthetic drugs that are really killing people. And the rise of fentanyl across North America is really the result of prohibition. And this is where we're at now. It's so clear to me dealing with people in this situation that most of it really comes from people's trauma in their lives, whether it's childhood trauma or what they face with and things that have happened in their lives. And until we again address this and deal with that, many people will be left outside of our care, and many people are vulnerable to death. There's in Canada, we've been really confronted with in the last few days the rise of the importance of residential schools, how we've dealt with our Aboriginal populations, and the findings of these mass graves of kids at residential schools in Canada. And the overrepresentation of Aboriginal people, First Nations people in North America in these types of addiction programs, and in having problems with substance use is really based on deep-seated trauma that we really need to confront and deal with. So as much as I think a medical approach and offering services and offering medications to help people deal with their problems is important, we really need to step back and try to reduce the stigma and the trauma and the problems that we put people in because of our drug policies, and not so much to do with the drugs. One of the things I was asked to talk about was kind of policy intervention. So I think that I've been part of a community in the downtown east side of Vancouver that has really been a laboratory in harm reduction techniques and interventions, and at the same time, really a laboratory of human suffering. And we've in Vancouver, we live in a very wealthy city, but we've have a real hurting spot in the middle of our city, which is a very dense population of people who are using drugs and suffering from basically a prohibition police state, and are in and out of jail, and are just struggling to survive. And we've been able to try out different interventions during that time. The downtown east side is known for one of the first North American needle exchanges. In 2003, we opened the Insight, which was North America's first government sanctioned supervised injection site. When I hear that kind of service is off the table in the United States, I just kind of shake my head. I mean, that is the prime way that we can engage with people and show people some sort of compassion. And to say that all the evidence we have, not only from Canada, but in the United States and Australia, to have Americans say that is off the table, to me makes absolutely no sense. That's probably one of the most important things that we can do, although it's not everything. So in 2016, when overdoses were going up, the provincial government of British Columbia called an emergency, a public health emergency, and allowed overdose prevention sites and supervised injection sites to open. There's now about 20 across the province, and they're busy, and they're a prime way to connect with people who otherwise have nowhere to go. It was also mentioned that COVID has really had a massive impact on isolation and reduction in services. And again, supervised injection sites really can serve to offset some of that isolation that people feel. We've also have quite an extensive community-based naloxone program. So many people have been trained with naloxone and carry kits at hand and intervene in overdoses all the time. But it's also quite clear that intervening in overdoses once they occur, whether it's at a supervised injection site or on the street with a naloxone kit or in somebody's house with a naloxone kit, is kind of a very late intervention. And for many people, it's too late. 80% of people that die of overdoses in the province are found alone and in isolation, and found after they've been dead for some time. And so as long as we have a criminalization of drug use, we drive people to the margins, and we force people into isolation and using drugs by themselves. And so although supervised injection sites do reach out to a proportion of people, it still falls short of getting people access to the care and the hope that they need. The other important thing that's happened in British Columbia, and some ways across Canada, is trying to give a voice to people who use drugs. So the medical system is extremely patronizing to people who use drugs. We throw around terms like opioid use disorder and over-medicalize things. I don't even actually know what overdose use disorder is. I see people all the time who use drugs, and it's very damaging to them. So by definition, they have an opioid use disorder. But at the end of the day, people are hurting and trying to cope, and are self-medicating. And whatever drug is most readily available and accessible and the cheapest is what people will use. And so there's areas in Canada where there's very little fentanyl use. It's all crystal meth. And that is because the drug is readily available, very cheap, lasts a long time, and people will do anything to try and alleviate the pain that they're feeling. And whatever drug is available is what people will use. And most people are using poly drugs, which really makes a big impact for the overdose crisis, because people will inadvertently sometimes and just periodically use opioids. The fentanyl is so potent that people are caught off guard and are poisoned. And we are trying to change the topic to get away from the overdose crisis to a drug poisoning crisis. So this is not people who are taking too much drugs. These are people who are taking drugs that they think are a safe amount, and it isn't a safe amount for them, and they're dying. So it's a massive poisoning epidemic that's happening across North America with these synthetic opioids. And as a public health practitioner, we should be focusing on this as a poisoning epidemic. And the first thing you do with the poisoning is to offer people an alternative to what's poisoning them. And that leads me to the safe supply. So really, you know, almost 6 years into this this poisoning crisis, I see that we have no alternatives but to offer people a safer supply of drugs. And that is what the community's calling for now, and I totally support that. There's really three things that we need to do. One is to give people access to a safer supply of drugs, including opioids. The second thing is to decriminalize drug use, so it allows people to come out of the shadows and stop this cycle of going in and out of jail for just using drugs. And we really need to make some gains in that. And the third, which is highly controversial, is defunding the police, or at least changing the structure of the policing, that it's not just officers out there trying to bust people for using and selling drugs, that these resources need to be spent in an entirely different way, providing people with access to support and housing and trauma counseling. And the idea that we can just arrest our way out of this is clearly unsustainable and unworkable. And along the way, pursuing these kind of policies has led to the untimely death of too many people. So those are the three things. And although Canada seems to be progressive, trying to get people into a safe supply program is an uphill battle for sure. And that's what I'm primarily working on right now with a hydromorphone project. There has been a long established heroin injection program, or hydromorphone injection program, in Vancouver called Crosstown. This was a part of a large clinical trial that's now over a decade old, and about 200 people go every day, 2 to 3 times a day, to inject heroin under supervision. And these programs are expanding a little bit around the province, but we really need to go even beyond that and demedicalize this entirely. If we're allowing people to buy poison and unknown drugs in an alley, it makes no sense that we're so concerned with giving people a safe pharmaceutical supply of drugs when they need it, to engage them in care. And that I really believe, to reduce the number of people dying in a hurry, that's what we need to do. So I'll end my comments there. And I have a very short video of a program that we instituted over a year ago now, called MySafe, and it's a machine that gives out hydromorphone pills, and it's pretty self-explanatory from the video. So if Sue, if you could show that, that would be great.
Yes, I'm gonna start, and just let me know if you're unable to hear the sound for any reason.
The last 5 years working down here has really been horrendous. Though we've done what we can to reduce the number of people dying from overdoses, the numbers say that we haven't done enough. It just makes no sense to walk by somebody knowing they're going to inject something that could kill them and not offering them an alternative when we have an alternative.
Really, the key criteria that we use for determining somebody's eligibility is, are they using street fentanyl? And as a consequence of that, are they at risk for dying?
So originally people were getting four times a day, but with COVID, we were able to respond by changing that from 4 times a day, accessing the machine to 1 time a day. So they're able to get their full day with that.
This program's great. Like, where do you see it? You can walk in, put your hand up to a machine, and it distributes what you need, right? I mean, that's great.
I was one of the first persons through the program here, and in fact, it's changed my whole life. Forming a great relationship with my grandchildren. I have an 18-year-old granddaughter that I've now been able to spend time with, and I'm not always running around looking to get well.
I used to have to wake up in the morning, do crime or something right away to make money. Right now, at least I just know I can come here. It takes away the stress. Kind of helped me stay out of jail, that's for sure.
There's literally tens of thousands of people in the province who are putting themselves at risk by buying toxic street drugs. And so we need to come up with programs that can really expand beyond very structured medical models of giving people injectable heroin or injectable hydromorphone.
So we see up to 700 people a day at OPS. Getting a predictable dosage from MySafe for the folks that we see every day is saving their lives. We see lots of people overdosing every day. Once they get on this program, their life changes absolutely.
My personal experience dealing with pharmacists and having to be moderated and told what to do is frustrating, and you feel like a little kid. And this puts it in your hands, how you want to deal with it, and limits the interaction and judgment that you would have to deal with going to a pharmacy.
How many people do you want to die before you decide that maybe hitting rock bottom isn't the best way for people to change? And it might seem counterintuitive to people, but giving them a safe supply of drugs is their first step towards reducing or not using, if that's what they want to do. And give them the opportunity to actually do that is, I feel, is the most important thing that I can do.
Well, that was fantastic. Thank you so much for sharing that. The spirit of this talk this series is to hear innovative solutions, and you both presented very intriguing and interesting ideas. I have several questions for discussion, and I want to have a good, vigorous discussion around this. But I do want to open this up for participants as well. You can use the Q&A box or the chat box to ask some questions. But I wanted to focus initially on buprenorphine. It's a medication for treatment of opioid use disorder, if we're going to call it that. And there's different regulations around it. In the United States, there was recently a change to the regulation of buprenorphine where a mandatory training was taken away. It used to be either 8 or 24 hours, depending on the type of provider. And I was curious about thoughts about that, but probably from Deepa more than Mark. For Mark, as far as like a medication like buprenorphine or methadone, instead of giving hydromorphone, I'm curious about the thoughts of that. And then I have so many other questions because there's so many interesting things, but maybe we'll start with that.
I could jump in on that question. So yes, you're right. There has been a shift in the regulation related to buprenorphine provision for the treatment of opioid use disorder. So prior to this shift, physicians had to receive 8 hours of training. Other healthcare practitioners that were eligible to prescribe had to receive 24. So the federal government has lifted that requirement for individuals who want to treat up to 30 patients with buprenorphine. One of the things I would say is, obviously we want to increase access to this medication. I think that is something that we could sort of collectively agree. But one of the things we've also noted is that there is not sufficient training on opioid use disorder and its consequences and how to treat it from mainstream medical education. So as I said, we really tried to push that, But one of the reasons that this law existed in the first place was because of the potential negative effect buprenorphine could have if diverted, if misused. And so to ensure that practitioners knew the complexity of treating opioid use disorder. So again, right now we've lifted the educational requirement and we will see what happens. But when we look at the data prior to the kind of release of this new practice guideline, what we saw is that we have plenty of providers across the country that can actually treat individuals with buprenorphine. It wasn't the educational requirement that was sort of standing in the way of that treatment. It's something else. So we'll see whether or not we sort of address the right problem and whether or not the lifting of that requirement will actually increase access. We're hopeful that it does, and we're hopeful that at the same time it doesn't increase diversion, but we'll have to see what happens with that.
Yeah, I mean, the formulation in Canada is Suboxone, which diversion, I mean, people, can't use it for injection. Diversion to me, it means that we're not meeting people's needs somehow. So if you can't get buprenorphine and you're willing to buy it on the street or get it diverted, it means that your system is not functioning very well because you're driving people to extraordinary levels to access this drug. So, but I think for the most part, Suboxone could be over the counter. I mean, it's people need it, and it should not be. There should not be a lot of barriers to getting it. Now, both methadone and Suboxone are fairly readily available in British Columbia. About a year and a half or so ago, maybe 2 years now, Suboxone or buprenorphine was made the first line therapy for people who want a substitute opioid. It hasn't really taken off. One of the things I hear is that it makes people feel very normal, and they don't really want to feel normal. And methadone gives people just a little bit of a bump when they get it, and they don't mind that, or they're looking for that. It's harder to chip away with Suboxone. So a lot of people on methadone continue to use some alternative opioids, and they can do that with methadone. It's harder to do that with if you're on a steady state of buprenorphine. So there's different reasons why it hasn't taken off. But people need to be at a certain level or a certain point in their trajectory before they want a substitution therapy. And people need to understand that methadone and Suboxone are basically abstinence-based treatments. They're treatments that we're saying, we don't want you to use these drugs, you can use these drugs, and we'll prescribe them and we'll put them under very strict regulatory basis. And a lot of people over time just cannot adhere to that strict regulation. And people are on and off these medications all the time. And it means a lot of people who don't last on them, they were never ready to be on them in the first place. And so there's a huge gap in people's readiness to adapt to these treatments, and they're not for everybody.
This raises a very interesting ethical conundrum. It's kind of this the paternalism of society versus the autonomy of the individual about what we allow. And there's models throughout history as far as tobacco and alcohol. Now marijuana in many states in the United States is becoming legal as well. And it's interesting to see as I drive by the local marijuana dispensary, which has a line out the door every day now. And the world hasn't ended, I have to say that much about it, although we do sometimes see complications. But the idea of making Suboxone over the counter is interesting. I mean, how do we balance that autonomy with the role of society and the government to try and protect? And I'm thinking, specifically, I have 2 teenage kids, right? I'm trying to minimize the trauma that they have as adolescents, so they don't feel the need to medicate. But where do you draw the line? How do we address that?
Well, I think that is that's the question. But when I first introduced the idea that we'd actually give people hydromorphone pills that they could swallow or inject, the biggest pushback was diversion. Well, what if these pills go missing? What if somebody takes them from the machine and runs out and sells them? Well, we have followed that, and people do sometimes give them away or sell them, but it's always to a friend or somebody who needs them, who is withdrawal. The idea that somebody would run to a schoolyard and hand them over to a grade 7 is just would never happen. So, but could it happen? Possibly, but the damage that we're doing to the people currently using these drugs, for the off chance that something would get diverted, is really not a reason to hold the whole process up. We need to do, put in place guards against that. But if we all, many of us have kids or teenagers or whatever. I mean, we don't want them using these drugs, but we won't stop it by prohibition. It's education and the things we can do to protect people from trauma and all the things that lead to drug use. We can protect it, but to be totally paralyzed in our response because we're so afraid that these drugs could be diverted somehow is costing hundreds of thousands of lives.
Right. And I would say that from our perspective within the United States, I do feel that the government does have a responsibility to ensure the safety of all people. So it's not some super rare instance in which a drug like this is diverted and a person has an adverse consequence. It's common. It does affect families. It does affect young people. It does. And so the government does have some responsibility to pay attention to those types of consequences in its solutions.
Thank you. There's a question in the chat, and this is, I think, to Deepa. It says the first speaker identified training and workforce development as a SAMHSA focus. Providing substance use treatment is a stressful and emotionally challenging job. Turnover in the field is quite high and has an impact on quality and continuity of care. Can you speak to progress or initiatives to psychosocially support workers across levels of training or improvement in working conditions in addiction treatment facilities?
Yeah, that's an excellent question. And it's something that we really, as a country, definitely, and across states, really need to do a better job of. For sure, we know that there is extremely high turnover. There's extremely low salaries. The burnout is tremendous. And that's one of the reasons we want to ensure that people are well equipped to handle treating these conditions, right? So that if you start to train on it earlier, if you start to kind of recognize what it is you're going into when you're treating these conditions, we definitely kind of want to make sure that people understand what it is they'll be facing. The other thing we want to do is we want to expand the workforce that's helping treat these populations, right? So that we're not just training a specialty care system, but we're also training primary care. We're training other people that are interacting with individuals so that if the intervention happens earlier, then you're not only kind of responding to an acute care crisis. So those are the types of things we're doing. We're also looking at ways in which we can increase, compensation for individuals who go into these fields, as well as things like loan forgiveness and student repayment and things like that to kind of incentivize people to go into these fields as well on the front end.
Yeah, I think that, we give ourselves quite a bit of credit in the medical profession of somehow not being understanding and empathetic. And I have many colleagues who I really respect for their empathy and commitment, but the institution of medicine is not very forgiving. Almost everybody who has issues with their drug use, or we think there are issues with their drug use, has had a bad experience with medical care and a very bad experience with the criminal justice system. So to think that, we can just tweak these institutions that all of a sudden will be welcoming to people who have been traumatized and have had very bad experience with it. We need to really think of the way we interact with people. And that's supervised injection sites, to me, is like the obvious example. Allow people to use in safety under supervision, and the connections that they can make with community workers and healthcare workers in that environment is just so much more productive and possible than telling them to come into an emergency department or a specialty clinic, or no matter how hard we try to make these clinics accessible, people associate them with trauma and do not feel comfortable in these situations. So we need to really reduce the barriers to access to care. And I think supervised injection sites, to me, is the ultimate way that we can do that.
Right. If I could just add, I totally agree in terms of it's the medical profession alone isn't going to do it. And one of the things in the United States that we've really tried to do is build the peer workforce. It's really try to get people with this experience who have lived experience in these conditions to be the ones to interact on the front line. So you're right. An emergency room doctor isn't going to know necessarily how best to reach that person, but somebody who have that same experience may be the person to get them the help they need, whatever that help looks like. So I think that is something the United States has really spent time trying to build, both recovery community organizations. So those are community organizations that are managed, kind of directed by people with substance use disorders who have achieved the recovery that they kind of define themselves as, whatever that is. And these are community organizations that have social kind of interactions in the community, as well as connection to the medical care when needed.
Excellent. And I'll say we are working in the front line in the ED. We are trying our best to reduce stigma and approach people, and and I think in a more objective and compassionate way as well, which we hadn't been doing for many years. So it takes time, but I'm hopeful we're making progress. So there's another question in the chat, which is for the supplying of safe drug supply piece, are there any studies on what it costs to offer the safe drug supply versus the cost of lives lost through overdose? ER visits, hospitalizations, criminal justice system involvement, etc. Whether access to the safe drug supply reduces involvement in these other more urgent or emergent and more likely more expensive systems. Probably something hard to study, I would imagine.
Yeah, I mean, the Naomi trial, that this Crosstown clinic that gives out supervised heroin and hydromorphone injections has been really well studied, and across the board in this trial, this very extensive, comprehensive evaluation. Time spent in the hospital, time spent in the criminal justice system, time spent in crime is all reduced. So it clearly is a very cost-effective way to do it. It's still a clinic that requires doctors and nurses. We're right now setting up an economic evaluation of the MySafe program, which is these hydromorphone pills from the pharmacy are 32 cents. And so a day's supply is $3. The technology is relatively cheap. So I think this is kind of a scalable model that clearly, studies that have been done in Vancouver, just an average person entrenched in poverty and street drug use costs between $50,000 and $100,000 per year with the criminal justice system, hospitalizations, and not to mention all the other intangible stuff. So the cost to society and the cost to that individual is astronomical. And so there's no doubt that giving these drugs, which people push back, well, why would the government pay for these drugs? Well, what you're doing now, my friend, is highly expensive. The government is spending a lot of your taxpayers' money trying to keep the situation as it is. And so these kind of interventions are extremely cost effective.
Thank you. We're just about at time. I just wanted to give each of you just like maybe a 1-minute response. I try to be an optimist and look through the silver lining of things like what we're going through with COVID. Have any of you noticed any changes from this crisis that we hope will last, or hope are helping people that are struggling from drug use? Maybe I'll start with Deepa, and you can say no too.
Yeah, sure, thank you. And I'll be quick. One of the major things that I think COVID has really done is it's changed the delivery of care in the system, so that we talked a good game about telehealth and about using technology to provide care, but I think we've really, really expanded our ability to do that. And I think that will continue. That's not something that will go away. And it's made care a lot more accessible to those who could not previously receive it.
Yeah, in a nutshell, I think that we weren't talking about decriminalization of all drugs 2 years ago, and now we are. So I think that, to me, that's light at the end of the tunnel, possibly. And the whole idea of a regulated drug supply, again, was not really talked about before COVID, and now is part of the conversation. So there's a little bit of optimism there.
Excellent. Well, thank you both so much for sharing your experience and expertise. This is really remarkable. This is what we had envisioned for this conference. We will be doing this every Tuesday for the next 4 weeks, and we'll be featuring a different part of the globe each time to hear these innovative solutions. We hope you'll be able to join us. We will be recording these as well, and we'll try and make proceedings too. I just wanted to thank so much to Deepa and Mark for your time and your stories and sharing today. I really appreciate it.
My pleasure. Thanks for asking. And people can feel free to contact me if they have other questions or follow-up.
Yeah, same. Thank you so much.
Great. And thank you again to the Harvard Medical School Center for Global Health Delivery, which really orchestrated all of this. And we look forward to the future sessions as well. So hope you have a wonderful day.
Thanks.